between 30 to 45, but geriatrics was not there in BDSM. So, when it comes to drugs are not suitable for geriatrics. That is what we have, and what we can do with that actually rests on your skills. In geriatrics, is this a sign, a symptom? The patient comes, the family of the patient comes, and the family comes and says that he sleeps 5 times a day. It's okay. Is she happy? Yes. But there's a problem on Sunday mornings. She wakes up and wanders in the room, and she's disturbing us. This is not a symptom. This is an expectation of the family. But sometimes there are compliance problems. The patient lives in Bursa, his children in Istanbul. Okay. He moved his home, he left his home, his friends, his property. This is another problem. And for mini-mental, we ask which year are we, or what is the date. No, he doesn't know. He doesn't normally know that. He doesn't normally make this, so this is not a problem. So, being elderly, there is a song which goes as, I know how it feels to be young, but you do not know how it feels to be old. I have a patient at the age of 90, and she's in very good condition. She visits me once a month because she doesn't have anyone to talk about. We talk politics, we talk this and that. This is not a therapy, but this is a social need. So, all her friends have died, her children are in the US, and she lives alone. She's healthy, she's in good condition. Time to time she gets on a plane and goes to the US, but her social life is so weak. That is why she comes and visits me. Another issue is the effect of spectrum. These people were not born at the age of 65. They have some neuroses, some personality disorders that they brought with themselves. So there is for instance, man at the age of 80, and he washes his hands very frequently. But this is his habit, so you can't do anything about that. Or there's another patient who was paranoid. When he was young, he didn't let his wife go out. So when you try to treat that patient at the age of 80, it's a problem. If there is a symptom there, does it always point to a disease, both in terms of duration, both in terms of severity? Because sometimes people can be obsessive, or can be some type of sad, so especially for elderly, it's difficult to cope with them. So what you have in your mind and what the patient is experiencing may not always be the same, and especially DSM in terms of these criteria is quite problematic. But what are the complaints of the patient? This is something, and the complaints of patient's relatives is something else. First, I speak with the patient alone because it may be easier. Sometimes the patient says that my relatives are beating me, and sometimes they express themselves better. But if you listen to the relatives, not always everything is the same. For instance, if she says that you stole my money, for a physician, it's very easy to say that don't mind, never mind. But this is not that easy for the relatives. Or waking up in the middle of the night can be easy for us to tolerate. However, it may not be that easy for the family. And in order to diagnose the patient with Alzheimer's, we say, is she asking the same questions all the time? Yes, the relative says that yes, it is the case. However, What is important for the physician, what is important for the family, and what is important for the patient may not always be the same. Sometimes a symptom does not mean one thing. When you speak of color, there are, as you can see, different types of colors. So the signs and symptoms being specific or not should be taken into account. So for major depression, diagnostic criteria: loss of appetite, depressive mood, loss of appetite and insomnia or oversleep. This is there for depression, this is there for anxiety. So there is an overlapping picture. In medicine, for diagnosis, there are certain prototypes. Like if the patient is presented with this and that, it means that disease. But if she's presented with this and this, then it means something else. But when it comes to geriatrics, typical symptoms are not always there. They may be mixed with other diseases, or they may have multiple diagnoses. So while I'm lecturing interns and at the faculty, we fail to learn the details of geriatrics. For instance, there is a difference between elderly depression and depression of young people. So in elderly, they may suffer from pain and lethargy, but for the adults, for younger people, it may be different. When it comes to diagnosis, I try not to stigmatize the patient with a diagnosis which is not helpful. You have dementia, you have depression, you have anxiety, so what? This is not helping the patient. Symptoms of the patient may not be classical, not fit DSM. So major depression, I mean, in all the diagnostic criteria, they are there, and it has presented with paranoid characteristics and preoccupation. So for each and every patient, I write down a paragraph. I write down symptoms, but I do not make a conclusive diagnosis. So maybe you may find it strange, but I don't think that DSM is very successful, especially for geriatrics. It's not very accurate because there are some other factors like physical diseases. For instance, dryness in the mouth. Is it because diloxetin? Or is it because diabetes? Or is it because the Parkinson's drugs that are used by the patient? You don't know it. You say there is mouth dryness and try to find a cure, but if it was a young patient, you can easily say that this is the side effects of diloxetin. There is another aspect of difficulty of diagnosis. Sometimes they may be overlapping excessively with others. For instance, there are some conditions which involve minor symptoms. They are not very severe, but they are prolonged, and in terms of suicide risk, they are equal to major depression. So there is no sufficient symptom for major depression. However, you need to treat the patient as soon as possible, as if he was speaking from major depression, because the mortality and morbidity are the same with major depression, especially in painful syndromes or in flatulence or for instance, an obsessive case. and he uses the toilet a lot. I pooed, I didn't poo. Maybe you may have heard of it in the elderly. I pooed, I didn't poo. I pooed sufficiently or insufficiently. So he's obsessed with his poo. Other than this, you ask, and he says that I'm happy. But if only there was no poo problem. Well, it's because anxiety and obsessive trait that makes him visit the toilet that frequently. The symptom is going to toilet very frequently, and even abuse of anti-constipation drugs. However, there is no diagnosis in geriatrics. Multiple physical diseases, organ problems might be confusing, creatinine levels might be high, there may be multiple white matter disorders, liver is not functioning very well. So it's not very easy to sort it out. This week I had a patient that visited me. She was suffering from bipolar and Levi material demise. She was agitated and she wasn't opening her mouth to eat. So she put her mouth closed. She was screaming, "Let me go and take me to the living room, and I want to sit by the window." So she was thinking about suicide. She was screaming all the time. Why is this the case? She was using 1 lithium per day and she was stable. So there was hypercalcemia on lithium. This happened 10 days ago. I was abroad, so the internalist stopped lithium, and as soon as the lithium is stopped, the patient started screaming. She was not eating anything, she wasn't accepting drugs, she was speaking about suicide, screaming 24 hours, and she had intensive hallucinations. There is an eating problem, there is dementia, there was severe depression, so CT was not possible. We opened PEG. First IV Neurodol was administered, although there was a DLB. There is no disease, but there are patients. Although we know her sensitivity, we calmed her down, and after 24 hours, we venlafaxine, venlafaxine and mirtazapine plus Seroquel were administered. She started feeding from PEG because she didn't take any food or any water. She wasn't opening her mouth. So yesterday, it was the first day of feeding. She was slightly better. We would administer drugs from PEG, and then we will close it and continue with the oral. So this is not something that you see in young patients. This is about the patients. There is no disease, but there is the patient. Conversion comes to neurology a lot. So these conversions, they perform Botox, they perform electricity, so different things. So they say that for conversion, they apply Botox for the last 3 years. Conversion is less in elderly because they develop their coping mechanisms or they get tired of life so much, but their coping mechanism and They're expressing themselves is different. As I said in the beginning, if there is an art involved in this, then it means that you need to make different clothes for different patient. DSM, I object to it. It doesn't tell us etiology, validity and reliability is problematic. It's designed for young patients, no diagnostic category for elderly, and it was deeply affected by drug companies. So attention deficit and hyperactivity is very frequent in children, and there are so many drugs, but autism's subtypes or Asperger's syndrome subtypes are not discussed in DSM. There are elderly specific cases, minor depression, subsyndromal depression. We have to understand very well the symptoms of the patient, and we have to record them very well. We don't know the etiology, so whoever says something, we accept it. If the response is better than placebo, then it's okay. For geriatrics, placebo is more complicated. There is no antidepressant whose efficacy is proven after the age of 80 or 90. Regular visits and regular talks have better effect than antidepressants. There are some studies. So communication in geriatrics is really important. We administer these drugs continuously, but are we doing good to them or not? We don't know. When we see some symptoms, the symptoms may be the precursor of something else. You start with major depression, but then the patient suffers from dementia, or there's an atypical table, or there's depression. Then it turns into vascular dementia. The patient, you start with depression, but then the patient becomes DLB. So the symptom at the beginning may be different within time, and symptoms are different for elderly, for young people. For depressive symptoms, adults are more effective, are presented with more effective, but for elderly, they are more nervous, they focused more on the idea of death, and attention and working memory or cognitive skills are more impaired in the elderly. However, for youngs, the patients suffered from preoccupation or attention deficit. However, these problems may be very severe in the elderly. So when we see a symptom, what should we do? First, we should look at time. For hallucinations, let's say, if there is hallucination throughout the day, then we get away from delirium. However, if she dreams only in the afternoon, then we can think about early symptoms of dementia or delirium. Elementary hallucinations are more towards dementia or delirium. There is a bug in the wall, there is a snake there, or there are genies, or there are fairies in the room. So these hallucinations, if they are in line with the mood, then depression and psychotic disorders might be there. If they are very short, they are at the delirium side, but if they take longer, it may be related to psychiatric disease. If there is confusion there, then it should be considered as delirium, and organic reasons should be sought for. Drugs of the patient should be evaluated. The patient is taken to emergency, and she was dreaming. And when you have a look at that, she went to a urologist 3 days ago. She was suffering from urinary tract infection. So a central effect anticholinergic was administered to the patient. So these problems evoke us to think of the drugs used by the patient. So if she has an insight telling her that she's dreaming, then acute dementia might be there. If there is no insight, then we can think about something else. This is not 100% correct classification, but it can give you an idea. Clinical characteristics may be overlapping. The patient was so withdrawn, not leaving her room, not interested in anything, and she's neglecting her hygiene, and she only eats if we give food. She wears the same thing every time we hear her. She speaks to herself, and she's not taking drugs by fearing that we are poisoning her. What do you think of that disease? Is it psychotic major depression? Is it schizophrenia? Depression and schizophrenia. So let's say the patient is at the age of 70. Then we rule out schizophrenia. It may be dementia, it may be depression. So it may be major depression, Alzheimer's disease, vascular dementia, Lewy material dementia, or frontotemporal dementia, an atypic one. So if the patient had these symptoms for 1 week, it can be anything else. But if she has them for 3 months, it can be even a brain tumor. So there's the MRI image. There is hippocampal atrophy. This is the atrophy. This is not atrophic. This is atrophic, slightly atrophic. So which one was dementia and which one was the other one? Can we tell? This is the atrophy. Which one is dementia? This one or that one? It's not possible to tell anything from MRI. So this MRI, this is exactly dementia. You can see how atrophic it is. Nearly hippocampus, there are holes in hippocampus, but this patient was not dementia. However, this seems like a dementia, but it's not that. There may be atrophy in hippocampus. So only this one. Hippocampus seems like very good, but the patient is dementia. So these diagnoses are not very good all the time. How specific are the tests? At the age of 61, patient hallucinations, inability to sleep at night, and until the patient's mother died, she took care of her, and when she died, she started living with the relatives, and they didn't let her do anything. When she was taking care of her mom, she was going to the market, she was going to shopping, did cooking, cleaning, everything. But after that, they stopped her from going out, but just to help her, her relatives said that, oh no, you don't need to do anything, you don't need to go out, you don't need to go shopping. And then she started dreaming. There are histrionic characteristics. She was thinking of her old days, her past days, and re-experiencing, reliving her past days. If she doesn't want, then no image appears. For instance, during her, when she was young, she had a fiancé and they were engaged for 4 years, but then they separated. And she was waking up very frequently to take care of her mom. She wakes up 7 or 8 times and goes to the toilet. So forgetting something or forgetfulness. Why mini-mental test is 19? It was performed wrongly. So the patient doesn't have dementia. She is a healthy one. But when you are told that she was dreaming and she is forgetful, then you may think of dementia. I'm telling this because tests are not very specific. The patient has MCI. She's not very healthy, however, not dementia. Her mother's tongue was not Turkish. She was Albanian. So I used an interpreter. That's why mini-mental is 19. Administering a drug is not always a solution. Up until now, the symptoms were not specific. We have to think differently. Diagnoses are not very specific. Tests are not very specific. MR is not very helpful. The best thing is the experience of the physician and clinical examination skills. Of course, in order to, you can look at the genes, cerebrospinal fluid to decide on dementia, but only from the clinical perspective, our job is not very easy. You may know STAR-D study. Drugs were tested on elderly to treat their depression. Remission rates are not very good. So drugs are not helping us all the time. What type of treatment, what type of drugs should be decided based on the needs of the patient? If we fail to identify the needs, then we may not prepare a good dress that fits the patient. What is the appropriate approach? We have to determine and identify the signs, symptoms very good. Anamnesis, observation, ruling out secondary causes, additional physical diseases, and find the best clinics that fits the symptoms. Use laboratory tests, review diagnostic possibilities, and keeping on monitoring the patient. Geriatric cases, the best treatment option is to see the patient repeatedly. What was the mini-mental at the time? What is it now? And when you see the patient, you have to be very careful, and that is why I say our job is quite similar to the work of a tailor. That's the end of my first speech.